What's that? You ready to go? A spring break cruise? Yeah.
It'll be 880.
Where do you go to? Oh, I got it. Well, this is pathology final today, is that right?
Our final test.
Excuse me? Is it the final exam tomorrow or today?
The final exam is 2 weeks. 2 weeks and 1 day from tomorrow.
What's today?
Very, very hard exam.
Number 5.
Boy, they must have you terrified. Infections of the central nervous system. Excuse me?
Pulling people in the A block.
Oh, the A? Right. So you're going to learn it all in the last 2 hours, huh? Is it multiple guess or multiple choice exam? Are all of your exams multiple choice? Well, we're going to talk about infections of the central nervous system in this hour. And then we're going to reward the faithful with a review and talk about, did I see some hands go up in the back? And I look forward to my usual nasty evaluations for people who didn't come to the lectures and hear the points drop that you're supposed to learn. Some terms about evaluating the infections of the nervous system. Pleocytosis is a 25-cent word for cells in the spinal fluid, white cells in the spinal fluid. Hypoglycemia is a 25-cent word for low CSF glucose. These other words are self-explanatory. Meningitis, inflammation of the meninges, encephalitis of the brain, meningoencephalitis, kind of a hybrid term, myelitis, infections of the spinal cord, and then you can have encephalomyelitis. So those are the key terms. Another term is the term parameningeal infection that you'll see, and that para means beside, so that's localized infection beside the meninges, of which the classic examples are things like brain abscess, subdural empyema, epidural abscess, suppurative intracranial thrombophlebitis, which means the veins that drain the brain become infected, and mycotic aneurysm, which is an infectious aneurysm involving the vessels of the brain. And what condition typically leads to that? Endocarditis. The spinal fluid formula, the red cell count in the spinal fluid is normally 0, but obviously you can have a traumatic lumbar puncture, correct? White cells normally less than 5, differential, all monos, and then the protein is usually 15 to 45, and the glucose is 40 to 70, or about 2/3 of the simultaneous blood glucose, and all of this is in your handout. Some pointers about spinal taps. If you think of it, it's best to do it. In chronic problems, there's a style of medical practice today is to get a CAT scan before you do the spinal tap to rule out a mass lesion, because if you have a mass lesion, you might herniate the brain. In acute situations, I certainly feel that if you have to delay to get the CAT scan, go ahead and do the spinal fluid and do the tap right away. Don't delay because it can be disaster if you have acute bacterial meningitis. Save an extra tube. Acute bacterial meningitis, we talked a little bit about meningococcal disease yesterday as a medical emergency. Endocarditis is sort of the syndrome of fever and a heart murmur. Meningitis is fever and a stiff neck. But we talk about other meningeal symptoms, vomiting, headache, lethargy, confusion, and stiff neck. And we talked about yesterday how people could be misdiagnosed as having gastroenteritis. Often, as in a case I gave you yesterday briefly, the clinical picture is unimpressive. So you go out and you're practicing medicine in Bamberg or Kingstree or somewhere, and you see 100 patients in a day, and one of them comes in, and lo and behold, it's got meningitis and is dead the next morning, and you're sued, and your day is ruined, your year is ruined, you might feel like your career is ruined, So it's a very scary condition. The triad of meningitis: fever, stiff neck, and brain dysfunction. Fever, invasion of the blood in CSF, stiff neck. It hurts to move the neck in this direction, anterior or posterior. You can do it that way all day long, although that might exacerbate it. We'll talk about that, but to move it in that direction really does hurt. And brain dysfunction, nausea, vomiting, headache, irritability. I'm going to skip Koenig's and Brzezinski's sign. Those are just signs that relate, that you'll pick up later on, that you'll that indicate that the neck is stiff. The syndrome of acute bacterial meningitis: purulent spinal fluid with more than 1,000 cells in the spinal fluid. That's essentially diagnostic, but that's not always the case. Increased intracranial pressure due to localized pathology is the only absolute contraindication to doing a spinal tap. And so I believe that if you can rule out papilledema by looking in the eyes, and there are no focal neurologic syndromes, go for it. Sometimes repeating the spinal tap may be important if the initial tap is not diagnostic or the patient fails to improve. You can make a presumptive diagnosis from a gram stain of spinal fluid, but the overall usefulness, as I mentioned, is about 1/2. In meningococcal meningitis, which we talked about briefly yesterday, and we'll talk about a little bit more, you may have only a few organisms which can be easily missed. The pathogenesis of meningitis, to be very brief, it's a familiar story of colonization followed by invasion, and then the bacteria multiplied. Much of the damage is caused by your host defenses. One problem with the spinal fluid is that because of the blood-brain barrier, the concentration of antibodies and complement is fairly low in spinal fluid. So phagocytosis is inefficient. So a lot of the problem is due to host defenses, your leukocytes rushing in and causing this intense inflammatory response. And that can chew up your brain, and that's one reason particularly pneumococcal meningitis is especially bad, because of the very intense chemotactic stimulus. And this is shown schematically here, and we note here that there are 3 ways that the brain can swell. It can swell from increased permeability of the blood-brain barrier. It can swell from increasing the resistance to outflow of CSF, leading to an internal hydrocephalus and cytotoxicity from all this going on as well can cause edema. So 3 different ways that the brain can swell. You can also develop vasculitis and infarct the brain. All of this leads to decreased blood flow to the brain, which is kind of the final common pathway to death, isn't it? Pathogens have a lot of offensive strategy. They have most of the bugs that do this. Some of them have adhesive pili, the ciliostasis, et cetera, et cetera. And the polysaccharide capsule of the so-called big 3. What are the big 3? Excuse me? Can you guess? Big 3 encapsulated organisms that cause meningitis. Excuse me? H. influenzae, that's good. And meningococcus is 2, and the pneumococcus. Those are the 3. And those 3 have led to making vaccines against the polysaccharide capsule. And the breakthrough in the last 10 years has been the vaccine against Haemophilus influenzae. And the host got its own strategies, but they don't work particularly well, as we have seen. The blood-brain barrier in adults is quite efficient. We talked about bacteremia yesterday, and it's uncommon to get meningitis as a result of bacteremia. However, as noted, the blood-brain barrier has to mature, and so in little infants, about a third of the time, if they get bacteremia, they will get meningitis. And so what might you predict about the spectrum of pathogens in the perinatal period? Yeah, exactly, maybe a lot broader. Group B, B as in boy, streptococci, Listeria monocytogenes, E. coli, lots of other organisms. The spectrum of pathogens is broader there. Interestingly, experimentally, the barrier seems to function unidirectionally. If you put bugs in the subarachnoid space, that'll cause bacteremia about a third of the time. And here we look at the blood-brain barrier a little bit. Normal functions, major sites, the arachnoid membrane, choroid plexus, endothelial cells. And then in meningitis, various cytokines increase the permeability of the blood-brain barrier, and that's bad in that it lets stuff in, it leaves the brain to swell. It's good only in that it lets antibiotics that normally wouldn't get in very well also get in. And the cytokines, the key ones here, you know all that stuff, interleukin-1, tumor necrosis factor, et cetera, et cetera. So why is meningitis so devastating? Well, I think we've shown that. The increased permeability of the blood-brain barrier and the brain edema. And complications of meningitis that require supportive care, seizures, aspiration, hyperthermia, hyponatremia, hypotension. Other organ systems can become involved. Hydrocephalus, subdural lymphoma. So it's a bad thing to happen to you. Now, this slide summarizes the key pathogens in meningitis: neonates, E. coli, group B strep, Listeria monocytogenes, and then other bacteria. Then H-flu takes over, although the H-flu vaccine has made this an uncommon disease. But this used to be sort of like the number one disease in pediatrics up until just a few years ago. Then the meningococcus, and then the pneumococcus. From age 5 to 30, think of the college-age kid, meningococcal disease in college-age kids. The meningococcus is the primary pathogen, and then the pneumococcus. And then the rest of life, the pneumococcus takes over. It's a number one cause. Other gram-negative bacteria can also do it, and then as you get older, above 65, more cases from Listeria and aerobic gram-negative rods. So here are the big three, and not all polysaccharide capsules are equal. Pneumococcus, numerous serotypes, about 20% cause 80% of invasive disease. H-flu, there are actually 6 different types, but type B is the one that we particularly worry about. Meningococcus, most of the isolates are fimbriated that cause meningitis. So we're going to talk about these some of these causes of meningitis. H-flu, why does it begin after 3 months? Maternal antibodies wear off, right? And H-flu meningitis may still be, maybe wearing off, the most common cause of acquired mental retardation. Complications, subdural effusions, anoxia. A lot of bad things happen. The kids lose their eyesight, hearing, through all the inflammation. 93% of the cases were under the age of 5. This is H-flu, and let's say what it is, describe it. Small, pleomorphic, gram-negative coccobacilli, right? Yep, huh? Okay. Small, pleomorphic, yeah, it's like a little coccus, right? That's the bacillus. That's a huge elongated bacillus where the cells are dividing like that. So that's H. flu. These data, published in 1933 by Fothergill, show the inverse relationship between the observed incidence, this is years, going from this age 2 there, age 5 here, adulthood here, age 3 months there, the observed incidence of H. flu meningitis and the prevalence of bactericidal antibodies against H. flu in the blood. So the storyline is, of course, I mean, it's very dramatic that after your maternal antibodies wear off, the disease peaks, and then by about age 5, people start to wake up to H. flu as little kids get red ears, et cetera, et cetera, et cetera. And we see that by adulthood, he found that all people had bactericidal antibodies against H. flu. The incidence of H. flu meningitis might have increased in the second half of the 20th century because kids began to get antibiotics for their red ears, right? And so they didn't make antibodies to the H. flu. They didn't have enough chance to make antibodies to it. Current issues: low case fatality rate, drug resistance, daycare centers is a preventable disease. Meningococcal disease we talked about yesterday, and we showed pictures of the rash. And there's a spectrum of, if you did a Venn diagram of meningococcal disease, some people have the syndrome of meningitis, some have the syndrome of meningococcemia, and a lot have both. Very large overlap. You notice about 30 to 40% have meningococcemia without meningitis, and about 10 to 20% of cases, of course, is fulminant, and up to half of these people die. So chronic meningococcemia occurs, but it's rare. So it's a very devastating disease. And usually the scenario is that you're colonized with it, you're an asymptomatic carrier. We spend a lot of energy trying to treat secondary cases or prevent them by prophylaxis. Now that's been simplified, so you give one dose of Cipro to everybody in the dormitory or whatever. As was the case with H. flu, the age incidence is almost exactly the inverse of antibody prevalence. Also with meningococci, all of us are exposed to it as we go to school, et cetera, et cetera. It's a systemic disease when you have meningococcemia, myocarditis, widespread hemorrhages. This is a meningococcus and spinal fluid. What do you see here on this gram stain? Sure, these are gram negative, and I think I can tell you that this is like 2 Krispy Kreme donuts stacked on top of each other. Not quite. It's a tough cell, biscuit-shaped, gram-negative diplococci. And one point to make is that if you look at the morphology of the meningococcus and the pneumococcus, with the meningococcus, the long axis of the pair of organisms is perpendicular to the long axis of the individual cells, whereas the pneumococcus, the long axis of the pair, is parallel to the long axis of the individual cells. That can be important in interpreting a gram stain, which might be decolorized wrong. And this is the meningococcus on a scanning electron micrograph, showing it is sort of a flattened, I think it's the best example of looking like 2 Krispy Kreme donuts. It's a little short, plump coccus. And the problem is, you can see it's an uncommon disease, so all those folks lined up to see you in your clinic outside of Swansea, South Carolina, right? One of them might have meningococcal disease, and the question is, which one is that going to be? And serogroups A and C are the ones that classically cause the big epidemics, where only about a mile from here was a meningococcal disease at one time in our not too distant history rampant. Excuse me? Main campus? No? Where did tragedy after tragedy occur from meningococcal disease? What? Anybody? Let me give you a hint. Someone came around to you and said, "Cut your hair, whip your fanny, put you in the army, boy." Fort Jackson, sure. Fort Jackson, which is, if you go by, you'll see the sign, Camp Jackson, World War I. These boys were sent from all over the country, and in army barracks, meningococcal disease would spread around, and they would just get sick and die. That was very rampant. Pneumococcal meningitis, I covered meningococcal disease yesterday to a large extent. Pneumococcal meningitis, the major cause of meningitis in adults. In pneumococcal meningitis, in contrast to meningococcal meningitis, most patients with pneumococcal meningitis will have a predisposing cause that you'll find on examination. Otitis, sinusitis, pneumonia, skull fracture, endocarditis, alcoholism. Usually you can find a story with pneumococcal meningitis. The problem with pneumococcal meningitis is that because the patients often have another problem, some comorbidity, the diagnosis is often delayed with tragic consequences because there is, of course, a very intense inflammatory response in the brain. This is a major cause of acute meningitis in adults, 20 to 60% mortality. Half of the survivors have residua. Pneumococcal meningitis. And describe what you see here in this gram stain. Anybody? Right. You got it. Good. You got elongated, so-called lancet-shaped diplococci. They're more elongated, so you can see how that morphology, even if the gram stain was wrong, you'd say something's rotten in Denmark because of the way they're lined up. Another observation that this slide inadvertently, I shouldn't say inadvertently makes, is that look at there's a disconnect, isn't there, between all these polys and the bugs. Remember I showed you that nice gram stain of clap yesterday with all those bugs in individual cells? Here, can you find a single example of a poly that's got bacteria in it? No. And so I think what this tells you is that, again, phagocytosis is very inefficient. So what happens is that because of all the cytokines, et cetera, that are being released, polys keep streaming into the CSF, but they can't do a thing. So more of them keep streaming in. So you get pus on top of the brain, and this is what really does you in. Neonatal meningitis from gram-negative rods, some infants are predisposed. E. coli, about 60%, other gram-negative rods. Interestingly, about 80% of the E. coli that do this express a capsular antigen, which may play a little bit of the same kind of role that the polysaccharide capsule of the big three plays. And adults can also get gram-negative meningitis after, say, neurosurgery, head trauma, associated medical problems. And in fact, some studies indicate that gram-negative meningitis in adults is a major problem, particularly related to neurosurgery. Listeria monocytogenes is an uncommon cause of meningitis. What is, you had listeria in an earlier lecture. What is unique about listeria, or not, doesn't make it completely unique, but what, excuse me? It does it? I didn't know that. It grows in a refrigerator? Or you just make that up?
It likes cold.
It likes cold, okay.
Not what we were going for.
It's an intracellular pathogen. There are a few bacteria. Salmonella is one, Brucella is one, Listeria is one, that are intracellular pathogens, and therefore T-cell immunity is important. I guess one hint is monocytogenes. It affects little babies, but also older people as our T-cell immunity wanes, and say people who got steroids or were immunocompromised. It's a more subtle disease. This is Listeria. It's a gram-positive organism, gram-positive rod that might be mistaken on a gram stain on a culture for a contaminant. So here's some associations with meningitis. Turns out that actually a study in Charleston, South Carolina, lower SE status increases the risk of H. flu meningococcus. Immunosuppression, bad immunity, Listeria. Skull fracture. After a basilar skull fracture, the pneumococcus is the most common cause. If you have a little congenital dermal sinus, which might be a little hole that you'd see in the midline anywhere from the base of the skull on down, but usually on the base of the skull or down and around the sacral area, congenital dermal sinus, that could be a straight shot for skin organisms to get in and cause meningitis. Any questions about meningitis? A whirlwind overview. Aseptic meningitis is essentially, in clinical terms, synonymous with viral meningitis. This is probably a lot more common than bacterial meningitis. The term was operationally defined by this fellow in two definitions 25 years apart. The first one he described as a disease with acute onset, meningeal symptoms, cells in the spinal fluid, usually monos instead of polys, with sterile cultures, a benign course, short duration, and recovery. And then in 51, he revised this as a syndrome of multiple causes and not a specific etiologic illness. So this is essentially synonymous with viral meningitis, but as you can see, it is a tincture of time diagnosis, although some recent studies suggest that using the polymerase chain reaction, you can make an early diagnosis of the most common type of organism that causes this, which is what type of virus? An enterovirus. An enterovirus. It's the current operational definition, a syndrome with meningeal irritation, pleocytosis, absence of organisms. The term viral meningitis is permissible if the course is typical of an acute viral process in a short, uncomplicated course. But she noted that many other processes can mimic this. Enteroviruses cause about over half of the proven cases, typically tend to be a summer disease. Lots of other viruses can do this, as noted here, lots of them. And beyond viruses, you can get other causes as well. Enteroviruses may have a rash that could sort of fake you out into thinking that this was meningococcal disease. These patients do not get as sick as patients with bacterial meningitis, and obviously careful evaluation is important so that you don't commit the patients to a course of antibiotic treatment. One pearl is that the CSF glucose is usually normal in viral meningitis, although sometimes it can be low. Mumps can do this with a low glucose, and some others can cause a low glucose as well. Sometimes, if the clinical picture looks like aseptic meningitis, but the CSF formula is confusing, if you simply wait and repeat the spinal fluid LP in about 6 hours, you'll find a reversal, so that now it's all lymphocytes, or mainly lymphocytes, without treatment. In bacterial meningitis, except for Listeria meningitis, it's obviously going to be overwhelmingly polys. And as you see here, numerous more serious things can look like aseptic meningitis, including tuberculosis. Partially treated bacterial meningitis is a very big one because a lot of people will have gotten antibiotics. A high protein may be the key to partially treated bacterial meningitis. Syphilis can cause aseptic meningitis, particularly secondary syphilis, toxoplasmosis, sarcoid, drug reactions, other things. Any questions there? And chronic meningitis is, what are the two major causes of chronic meningitis? Here it would be tuberculosis and fungi, particularly cryptococcosis. In the southwest you would add coccidioidomycosis. Some combination of fever, headache, lethargy, stiff neck, frequent elevation of protein, predominantly lymphocytic pleocytosis, low sugar, and you would distinguish this from aseptic meningitis because it just doesn't go away. TB, crypto, fungi, lots of other causes, but the syndrome of chronic meningitis, and every time I get a case of this, I go to the textbook and check myself on the broad differential diagnosis because lots of things can sometimes do it if you don't get a ready diagnosis up here. Tuberculous meningitis, we talked about in the earlier lecture how in tuberculous meningitis, with careful evaluation, you will find in every case a tubercle right underneath on the surface of the brain that then ruptured into the subarachnoid space, leading to the inflammatory response. And this is a really tough diagnosis to make in a lot of people. Cryptococcal meningitis is strongly associated with AIDS today, but it can occur in people without AIDS, particularly people who are immunosuppressed, but also other people if you happen to go in a chicken coop and get a large whiff of cryptococcal organisms. And that's a very, very serious disease. And this is Cryptococcus neoformans on an India ink prep, showing this very large, extraordinarily large polysaccharide capsule. And Dr. Mayer invented the Mayer's Musi-Carmen stain, but somebody stole his patent, which is why he's sitting back there. Stains it red. Syphilitic meningitis is rare. Half have focal signs, usually subacute. Can be a kind of a tough diagnosis to make. Herpes simplex encephalitis we now go to. Viral encephalitis, the question is, does the patient have meningitis or encephalitis? Clinical diagnosis to make. The most important cause of sporadic viral encephalitis today is herpes simplex. And no, this is not a sexually transmitted disease. We really don't know why some people get it. I tell people it's like being struck by Zeus, but it's a bad thing to happen to you. It's a necrotizing process. Tends to involve so you get red cells in spinal fluid. Tends to involve the temporal lobes, and it often will present, especially if it's in the dominant hemisphere, aphasia, speech impairment, also bizarre behavior, hallucinations. It has a very high mortality rate. Today we use the polymerase chain reaction to show HSV in the spinal fluid, and we overtreat this disease because there is a drug now that you can use to treat it with, so we tend to grossly overtreat it. Herpes encephalitis, very big. Brain abscess, another thing that can happen to you, and this is an example of what type of infection? A blank meningeal, earlier in the lecture. Parameningeal infection, right? Parameningeal infection. Classically, fever, headache, and focal neurologic deficit, but notice that a minority of patients have all three of these problems. It tends to come on slowly, and the patient comes into your office with symptoms that very well tell you what part of the brain is involved, i.e. they're behaving in a funny way or goofy, they've got one in the frontal lobe, problems with the speech, it's in the temporal lobe, et cetera, et cetera, et cetera. Brain abscess from CT scan, showing here. And this tends to be mainly an anaerobic disease. This is the pus from a case of brain abscess, foul-smelling pus. Presentations often that of a nonspecific mass lesion, and I've seen over and over again patients who came to surgery for presumed brain tumor and were found to have a brain abscess. About 20% are cryptogenic, meaning we have no idea where it came from. The rest are secondary to a contiguous or distant infection or trauma, including neurosurgery. for some reason they got a brain abscess. Infected ear, mastoiditis used to be a major thing, sinusitis, frontal ethmoidal sphenoid. For dental sepsis, we talked about how maxillary sinusitis is the one that's usually fairly benign. Predisposing factors, lung abscess, empyema, bronchiectasis, infection anywhere in the face of a right to left shunt from a congenital heart defect so that the pulmonary filter would be bypassed. Streptococci, the most common cause. Other anaerobes, sometimes Enterobacteriaceae, fungi, sometimes pneumococci, but overwhelmingly streptococci, and often a mixed aerobic anaerobic infection. Here's one in the frontal lobe. In this case, watery, thin, foul-smelling pus. Subdural empyema, pus on top of the brain. Uncommon, usually from frontal sinusitis. Another anaerobic disease. Cavernous sinus thrombosis is a real big one, and this is why we don't pop zits around our nose and this part of the face, a dangerous area. Staph, the most common cause. So think of zits, staph, cavernous sinus thrombosis. And these people develop unilateral swelling of the eye, exophthalmos, edema, and they get cranial nerve palsies. This is a patient with cavernous sinus thrombosis when you see something like that, and that's obviously very serious and very life-threatening. Spinal epidural abscess. Fever, back pain, motor or sensory deficits, fever, localized back pain. Staph aureus, the most common cause. And MRI, now the procedure of choice. It used to be tough diagnosis. MRIs have certainly simplified lots of things in medicine, including this. So an MRI is now the diagnostic procedure of choice. And we finished this lecture early, and we'll resume in about 10 minutes